Okay, so welcome to the 13th Journal Club meeting for February. You've already put your points in, but so we'll go ahead from there. So the purpose of Journal Club, it's basically to introduce you to published literature, gives you exposure to like research papers in a low stress environment that you may see if you ever work in a laboratory or future in the medical field. It gives you a space to practice your presenting of research and exposes you to different different areas of academia. So basically, what we expect out of participants is to just have read the article before. At any point, you can bring up your own ideas, question the methodologies of the paper, discuss the applications, especially relating to medicine, practice reading literature, identify common structures to research papers, and then take notes and annotate if needed. So the article for this time is about Nirsevimab for prevention of hospitalization due to RSV in infants. So that was recently published in the New England Journal of Medicine. So for background, RSV is a common seasonal acute lower respiratory tract infection in younger children. It's actually the leading cause of hospitalization in infants. Currently, the safety and efficacy of monoclonal antibody Nirsevimab for treatment of RSV-related infections in healthy infants is unclear. So basically using that as a preventative measure. So the half-life of Nirsevimab is 71 days. Therefore, it can be administered previous to infection as a preventative measure in RSV in infants that it may be susceptible in the upcoming RSV season as it's known. So Harmony is a phase 3b randomized trial for the safety and efficacy of the Nirsevimab injection compared to standard care for RSV-associated hospitalizations in infants less than 12 months old. So basically standard care, that would be no preventative measures taken and then treatment when RSV does arise. So the purpose or hypothesis of the investigation, they wanted to test whether Nirsevimab is one effective against preventing RSV, and additionally, if there's any safety concerns in those infants. So they hypothesized that it would have greater efficacy in prevention of RSV compared to standardized or no treatment. So the methods and design. So they use random assignment for treatment or the control group in a roughly 1-to-1 ratio. There's 437 participants in the treatment group and then 421 in the standardized treatment group, or what would be known as the control group. So participants, they were infants less than 12 months, born at a gestational age of at least 29 weeks. Premature babies are more susceptible to disease and infection, so trying to control that. They received treatment before or during RSV season, typically the winter months, like most other respiratory diseases. The primary endpoint, or basically when they considered an event occurred, was hospitalization for RSV-associated tract infection. And they verified this through 1 hospital admission and then 2 a positive RSV test. The secondary endpoint was the severe RSV infection. So verification with this, they had to meet the primary endpoint, additionally with an oxygen saturation of less than 90% or need for supplemental oxygen. So the results. So for the efficacy, the hospitalizations due to RSV, 11 individuals in the Nirsevimab group at some point were hospitalized due to RSV, and then 60 in the no treatment group. So as we can see, significant difference between the percentages of each. So the Nirsevimab efficacy was 83.2%, considered within that 2022 to 23 RSV season. And then the superior efficacy, which is basically just comparing how the efficacy of the Nirsevimab compared to the standardized care, was 83.3%. So again, this graph just shows once an individual is admitted, it decreases. Additionally, this part is broken down by age, weight, and gestational age. Pretty similar results between the two, but as we can see, the standardized care, they do have the higher number of individuals that contracted or and were hospitalized due to RSV. Additionally, they considered severe RSV. So there was 5 individuals in the treatment group that first contracted RSV, and then it was severe enough to meet that mark. And then 19 individuals in the standard group. So the efficacy of Nirsevimab for severe RSV is 75.7%, and the superior efficacy for the Nirsevimab compared to the control was 75.4%. So in relation to safety, there was similar adverse events between the two groups. There was no significant statistical difference in the amount or the specificity of the adverse events that occurred. Additionally, majority of the adverse events in the trials were between a grade 1 or 2 in severity, so not very severe. Grade 3 is usually when it's considered a more severe adverse event. So from this, the researchers concluded that there's no more substantial safety concerns for Nirsevimab treatment for preventative care. So, in conclusion, they decided there was a greater efficacy for Nirsevimab for prevention of those respiratory infections compared to standardized treatment or no treatment. This was conducted in a real-world setting, so infants with their parents going to pediatricians, going to the hospital, and other preventative places. There's no substantial safety concerns raised. So the findings were similar to the previous trials. One difference from the previous trials was the researchers in this encouraged the administration of other vaccines for other sorts of infections that were age appropriate during the RSV season. The paper didn't go too much more into what they meant by this, but I'm assuming the previous researchers may have held off on administering other vaccines during the trial time period, just in case that added a different effect or bias towards. Additionally, there was no blinding of group assignment. So individuals, especially parents, caregivers, knew, okay, they're going to be in the treatment group or they're going to be in the control group. So this leads to limitations. So first of all, there was a short duration period of study. They really only observed for 3 months. It is an ongoing trial. They plan to do a follow-up at 12 months, but again, they haven't published those results of if there was any more adverse side effects longer down the road. Additionally, there's no blind assignment to groups. So there's randomized assignment, but the caregivers and both the medical professionals knew the group assignments. This may have encouraged or discouraged healthcare seeking behaviors on the side of the parents and guardians. You know, if you know your child has a preventative measure given, they might be less likely to take them to the hospital, or more likely, just depending. Additionally, 16 participants were hospitalized but not tested for RSV. So they may have had RSV but not been tested for, or it could be that some infants contracted RSV and just didn't show symptoms for it. So that also wasn't really tracked. Additionally, there was a limited geographical location, so primarily Germany, UK, and France. So potential for homogenous individuals, they really didn't break it down on like ethnicity, race, if any of those factors played into it, or just different geographical locations. Would these results still hold up? Were there any other limitations that you noticed while reading?
I think one thing that jumped out of me was the statement of funding. So the trial was like funded by I think Sanofi and was it AstraZeneca or
I
something
believe
similar?
so. Yeah.
Yeah, but they didn't state specifically that there were no conflicts of interest
Mm-hmm.
between like the two companies, which like blindsided me for a moment because normally when you like give out a drug or manufactured by these
Mm-hmm.
companies, then you would want the drug to pass through clinical trials.
Mm-hmm.
So what did do you have like any comments on that? Or
Um, so typically if like if they're directly funding those researchers will need to say usually at the end of the paper, like these are the potential conflicts of interest. These are like potential financial incentives for us to approve of this, you know. So I
yeah,
mean, yeah, that's good that you picked that out. Yeah, AstraZeneca, one of the larger healthcare and pharmaceutical companies in the Europe, so that, yeah, I'm glad you picked that up. Did you have any other limitations that you saw with like the study design or anything like that?
I think my main qualm with it was how they administered or like then they gave parents and like caregivers like a training period
Mm-hmm.
to make sure that they fill out the electronic records.
Mm-hmm.
S- So if that was not accurately filled out, then they wouldn't be hospitalized or detected for hospitalization,
Mm-hmm.
which for me was like a weaker way of doing that. But given the scope of the study, they had like like thousands of infants.
Mm-hmm.
That might have been like the only way that they could get such data.
Yeah. Yeah, I know one thing they did say in the article. So they had about, I mean, about 8,000 participants. They did say they originally planned to have closer to 40,000. You
Yeah.
know, that would give more statistically significant results if it was that. So I mean that, yeah, that also could be another limitation, that smaller group size. Um, or what strengths stood out to you, study? What do you think they did well?
I think they did good with the follow-up and then like the establishing like a concrete endpoint
Mm-hmm.
because that can be really ambiguous depending on the treating physician because that like the decision of the physicians to hospitalize them or made on like purely clinical grounds is not influenced by whether or not they receive treatment or not.
Mm-hmm.
But the fact that the physician knew that the infant that they are treating received treatment or did not receive treatment could
Mm-hmm.
have potentially also affected like their choice to hospitalize them.
Mm-hmm.
So yeah, it's like it's a strength, but it's also a limitation in that sense.
Yeah. Yeah. I mean, it'd be interesting to see if they could figure out a way to have like the double blind, but you know, like
Yeah,
if the child or if the infant didn't receive any preventative measures, it's important that the physician know that.
yeah.
But so yeah, I would agree that is a limitation, but okay, we're gonna move on. Okay, so future studies. So this trial could be repeated again, either with a larger trial group like they originally intended, have that longer study period. I know they tried to keep it within the RSV months, but they could repeat it for multi-year longitudinal study, um, or test in different study populations. Does this hold up in different countries? Does it hold up in different groups within the same countries that they tested? Um, Additionally, they could test Nirsevimab's efficacy and safety as compared to other RSV preventative measures. There are RSV vaccines out there. There have been a few instances of severe adverse events with that. So there are reservations on the side of parents often on getting those vaccines for it. So this could provide a safer alternative instead of getting those RSV vaccines. But what does that efficacy and safety look like compared to those? Additionally, there could be a combination treatment with agents to prevent degradation of monoclonal antibodies. So with that half-life of 71 days, there are ways to try to prolong how long those antibodies last. So would one of those combination treatments help to prevent the degradation of those monoclonal antibodies, hopefully giving longer protection. Do you have any other ideas of what future studies or applications this could be used for?
Um, I don't know what explicitly mentioned, but I was curious whether or not like application of RSV in combination with not other agents, but like other methods of treatment
Mm-hmm.
for that specific condition could be effective because like drugs is only one side of the problem. You have like
Mm-hmm.
many other things. And also if they could develop like a improved method to like decide which infant to give or administer the RSV
Mm-hmm.
to ask as a preventative measure instead of going randomized.
Yeah. I mean
But
the
like you yeah.
Yeah. They could have also like looked at like which infants are more at risk. Like do any have like immune compromise? Are they exposed to other children? Like do they go to a daycare where they could get RSV from other kids, or are they just stay at home? Are they around their grandparents from who they can contract it? So it would have been interesting to see if they could collect some of that data. Um, Not just to look at that, but just see like could that have affected any of the results as well.
Yeah.
Okay. Do you have any questions or further comments on this paper?
Um, do you have like a specific reason why you chose the paper
Um,
or
I
did you think it
so
was interesting?
I thought it was interesting. It was also relatively recently published in the New England Journal of Medicine. So choosing these, I typically try to choose articles that were more recently published because when you do like go into the medical field and they have journal club meetings like this, it's often what are the new innovations within the field or what can we learn from newly published stuff.
Yeah.
So,
Um, I think that was it because some of my main concerns with the article were like already addressed.
okay, sounds good. I am going to stop the recording.